So today, the hosts, well, Santiago Munné will be the main speaker. He'll be presenting some of the work which is helped publish. I'm David Chrimes, I'm the Director of Business Development, and Tony Gordon will also be on for the questions at the end. He's our Global Vice President of Business Development. So Santiago Munné has worked in PGT and was one of the founders of PGT-A, has conducted many studies over the years, including the first published papers on fish and PGT-A. I myself have worked in PGT for 12 years, as has Tony Gordon, and we will be here to answer your questions and help channel them at the end of the presentation. So with that, I'll hand over to you, Santi, and we look forward to your presentation. Thank you.
Thank you, David. Well, first of all, a few disclosures, since I have a few conflicts of interest and affiliations. I'm currently the founder and CEO of, co-founder and CEO of Overture Life, which is a company doing automation for IVF. As a professor at Yale, I'm a founder also of other companies such as Phosphorus, MedAnswers, Homo Inventis, and I'm a consultant for Cooper Surgical and Ferring. Today, before we go into the depth of reviewing this paper, I'll do a brief summary of what's already known on the subject. So as you know, implantation rates decreases significantly with advancing maternal age, and there is a concomitant increase in aneuploidy rate with advancing maternal age. Basically, this decrease in implantation potential is solely due to aneuploidy. If, for instance, you replace a euploid embryo, then they implant equally well at any age, therefore eliminating the maternal age effect on implantation caused by aneuploidy, and that has been published in many studies. The first one was by Hartung et al., but also if you see the SAR data of 2017 and you compare PGT with no PGT, you would see that this is what you get. Therefore, a PGT improves implantation rates per transfer, reduces miscarriage rates, increases live birth rates per transfer, reduces time to conception, reduces time to pregnancy, enables confident single embryo transfer, because now you have a euploid embryo and a blastocyst, so you just need to transfer one embryo. But obviously it does not increase euploid embryos, and it does not improve cumulative pregnancy rates. These are two misconceptions that some people have about PGT, and that's not correct. There have been multiple methods of PGT, and the technology is evolving, and today we will review two of these techniques, one that is basically no longer used, which is our aCGH, and compare it to the one that is probably the standard of care now, which is next-gen sequencing. In this table, it's a busy table, but basically I try to summarize all these techniques by different parameters. One is how many data points the technique is analyzing. We started with fish with 11 probes, and now we're at 4 million data points being analyzed with next-gen sequencing AI2. The resolution has been increasing, and therefore we can detect more and more smaller pieces of DNA missing or extra. Right now we're probably at 1.5 megabases or so. And these techniques have been validated in different ways. Some have been more validated than others. So we could, there are a bunch of papers on false negative ascertained by reanalysis of embryos, but there are not so many papers on false negatives and false positives or clinical error rate detected on pregnancies. One of the first papers to do that was Scott et al. In 2012 with a SNP arrays in which they transfer blindly embryos, and they found out later that the aneuploid embryos, 4% of them did implant, so that the false negative rate was 4%. And then there are a bunch of things that these techniques could or could not detect. The most important one and relevant to this paper is mosaicism. Next-gen sequencing is the best technique so far to detect mosaicism. It detects about 20% of embryos as mosaic, or 15, 20, depending on the lab. But it can detect from 20% abnormal cells to 80% abnormal cells. And this is, if we consider that on average we biopsy 5 cells, it will mean 1 out of 4 or 4 out of 5, sorry, 1 out of 5 or 4 out of 5 abnormal cells. Therefore, the 20 to 80% range. So today, in this paper, we are going to find out what's the false positive rate of these techniques after embryo transfer. Regarding next-gen sequencing, more into this technique, because it has a higher dynamic range than other techniques, it allows us to detect triploidies, 69XYY and 69XXY. And now with the next version, which is not part of this paper, also it can detect all polyploidies. As I said, it can detect mosaics from 20 to 80%, percentage of abnormal cells, has higher resolution, and it has been well validated by reanalysis of embryos previously classified by aCGH. So in this way, it has 100% sensitivity and specificity compared to aCGH when the embryo is fully abnormal or fully normal. However, when we have mosaics classified by next-gen sequencing, aCGH, because it cannot classify them as well, they are usually diagnosed by aCGH either as aneuploid or polyploid. Sorry, as aneuploid or euploid. So here you can see that embryos diagnosed by next-gen sequencing, when we do aCGH on them, they will be classified either as normal or as abnormal. And this is the pregnancy outcome that we get after PGT by next-gen sequencing. If we transfer either euploid embryos, which is pretty good, mosaics, as you could see, mosaic embryos miscarry more, implant less, but some make it to live birth, and usually, well, so far, I think we have 800 embryos transfers of mosaic embryos that have implanted, and most all of them, as far as I know, have been morphologically normal. Or in a very few instances, some aneuploid embryos have been transferred, and as you could see, the ongoing pregnancy rate is dismal, 4%, and that was just one implanting, and it was phenotypically abnormal. This is data that has not been published that we are preparing with my friend Biotti, and basically, as you could see, we can define it even better which embryos to transfer based on 2 parameters, which is the percentage of abnormal cells, if it's 50% or more or 50% or less, and the type of abnormality, how complex it is. So the more complexity and the more abnormal cells, the worse the outcome, the worse the ongoing pregnancy rate. So let's focus now on the NYU study by Dr. Friendetal and co-workers, in which I'm one of the authors. The aim of the study was to determine the clinical error rate after single embryo transfer of euploid embryos diagnosed either by aCGH or by next-gen sequencing. The method used were single thawed euploid transfers. There were 846 by aCGH and 1,151 by next-gen sequencing. It is important to be aware that these were sequential. So sequential in time, so first these patients were treated by aCGH, and then the center switched to next-gen sequencing. So for purposes of ongoing or pregnancy rates, this is not a good design, but for purposes of detecting miscarriages and misdiagnosis, it is. So what they did is for pregnancy follow-up, all the deliveries that were phenotypically normal were considered as normal. Also, we checked the gender that was correct, the correct gender. And then we took into account all the prenatal diagnoses that were normal or abnormal, and products of conception, which in this study, at least 50%, on average, I think it's about 50% of the products of conception were analyzed, which is a quite high rate. Usually, most POCs go undetected or unanalyzed. And it's a pity because it's a great source of information for the patient, but not a lot of people do that. In this case, at NYU, they always try to analyze the products of conception. Very important also for this study was how we classified a diagnosis as a misdiagnosis. So at Cooper Surgical, what we did, what we are doing still, is that if we get an abnormal prenatal diagnosis or POC, the first thing that we do is to reanalyze that sample, the DNA, the leftover DNA that we have, and we always store this DNA. We reanalyze it again, and if it's abnormal, then we know that it was a human error. It shouldn't have been, probably it was a typo or something like that. This has occurred, I think, in 200,000 cycles. It has occurred only once, but it's a possibility. Usually, and most of the times, is normal, and therefore we do another set of tests. The first thing that we do is to reanalyze the DNA from the prenatal diagnosis or products of conception. This is specifically important with non-invasive PGT. Non-invasive prenatal diagnosis, because sometimes there are false positives. So if in this case it's normal, then it is possible that it's a prenatal laboratory error, and this has happened in a few occasions. If it's abnormal, again, then what we do is compare the embryo DNA that we have stored with the prenatal diagnosis. This has two purposes. If we find a discrepant result, then we know that the wrong embryo was transferred. So the prenatal diagnosis is not the same DNA as the DNA that we analyze. Then what we do is to compare the embryo DNA with the DNA of the parents. Here it could happen that it's the correct DNA, and that would mean, in this case, that it's an in vivo conception. This has happened occasionally, so it's another source of non-misdiagnosis, because there was no misdiagnosis, it just was another type of error. On the other hand, if we have, when we compare the embryos of the DNA of the embryo with the prenatal diagnosis, and they are concordant, then again, we compare the embryo DNA with that of the parents. And if we find that they are the incorrect parents, again, the wrong embryo was transferred, probably an embryo from another cycle. Or if it's the correct DNA of the parents, then we have a technical misdiagnosis. Most of the misdiagnoses that are in this paper, not most, all of the misdiagnoses that are in this paper are technical misdiagnoses. All the others were eliminated. I don't think that there was any in this situation, but they would have been eliminated because we don't consider them a misdiagnosis, unless it was a human error. So in total, there were 19 of these misdiagnoses, 1.3% in aCGH and 0.7% in next-gen sequencing. Of those, as I said, the majority of them were products of conception. And we were able, as I said also, that to analyze 50% of these products of conception. And interestingly, there were many more abnormal ones in the aCGH than in the next-gen sequencing. Now, because 50% of these POCs were not analyzed, I would assume that the same rate of abnormality is in the ones that were not reanalyzed. And therefore, we could extrapolate that the real error rate is higher. It will be 2.4% for aCGH and 1.1% for next-gen sequencing. Still, it seems that aCGH had double error rate than next-gen sequencing. These are the results of this misdiagnosis. If you can appreciate it, there were a majority of these mistakes, especially in the next-gen sequencing, were mosaics. But still, there were 2 instances of full chromosomes that were missed, 17 and 11. And this was more often in aCGH. As a byproduct of the study, we could see also that there was a significant improvement in ongoing pregnancy rates. And there have been other studies showing the same, that you get slightly higher ongoing pregnancy rates when using next-gen sequencing than aCGH, with the caveat that all these studies, aCGH was done before, and then people moved to next-gen sequencing. Therefore, they are not well designed for this purpose, but at least it gives us an indication that that things are progressing, either in ABF or in PGT. So in conclusions of the study, next-gen sequencing produced half the clinical error rate of aCGH, and next-gen sequencing results seem better than aCGH clinically, with the caveat that I mentioned. But still, errors persist. So there were non-diagnosed mosaics, and also there were full-on euploid missed. Before I go to the next subject, which is how we can minimize error rate, I would like to also point out that these non-diagnosed mosaics could be originating not at cleavage stage or not at the stage that we are looking, but much later on, in first trimester or second trimester. And those obviously would not be detected at the level that at blastocyst biopsy. Those they have been reported that it's a typical phenomenon in placentation, and also there are a bunch of models in which, for instance, Bolton, Popovic, Victor et al., showing that mosaics originating at cleavage stage and pre-implantational stage, the abnormal cells either die out, or if there are too many abnormal cells, then the embryo doesn't survive. Meanwhile, the euploids tend to take over. That's why in the 800 embryos that we have analyzed, 800 transfers of mosaic embryos, we have not seen a single mosaic pregnancy so far. So how can we even further reduce misdiagnosis rates? I think one of the key points that we need to be aware is that depending on the biopsy, we can be creating some false errors, because, for instance, this is a paper by Whitney in which they point out that depending on who was doing the biopsy, if they were doing a poor biopsy, you could create artificial or artifactual mosaic results. Also, another paper by Herrero Grasa found that depending on the type of biopsy, also one was producing more artifactual profiles than the other. So it's important to be aware of this. But despite of that, There are now techniques that can differentiate between artifacts and true mosaics. And this is the new version of next-gen sequencing, PGT AI2. Basically, this is combining artificial intelligence. So it does a diagnosis of the mosaicism by itself, and it's trained based on 1,000 ongoing pregnancies and more than 10,000 embryos. It also includes diagnosis that of SNP arrays, and therefore we are not only analyzing the data quantitatively, but also qualitatively. And that gives you a double way of analyzing the sample and being able to detect if the sample are artifacts or true abnormalities. And also parent sequencing, which allows for reading the DNA fragments from both ends, thus increasing the amount of quality of data, improves sequence alignment, and allows performing higher sensitivity analysis. So with this improvement, hopefully we'll be able to further reduce even more the rate of misdiagnosis, which is, as you can see, still quite low. It's very low, around less than 1% with next-gen sequencing, and therefore not the cause of great concern that some people have. With this, we hope to be able, as I said, to differentiate mosaics from artifacts. Because the reporting is automatic, there will not be human errors. It will result in some more euploid embryos being diagnosed. And also because it's artificial intelligence, it continues to be self-improving with new data. Can detect all polyploidies, detect uniparental disomy, and probably can also detect balanced translocations and be able to do carrier mapping at the same time, although these two last things have not been completely validated yet. And with no further ado, I leave some time for questions and answers.
Thank you very much, Santi, for that really interesting review of the paper. I think it's a very brave paper. You know, not many people actually publish misdiagnosis rates, and it's very, very good to see that being published. So we have some questions that we wanted to go through, and we've had a few questions in the Q&A and the live chat on the theme of accuracy of mosaicism detection. And one of the questions came up and saying, as you know, there is the soccer ball theory of trophectoderm, where you have a patchwork of euploid and aneuploid cells, and it's been postulated that because of that, mosaicism detection of PGTA can never be accurate. That's the theory. I think this is possibly the data. How the data fits with that theory?
Yeah, mathematical models are cute, as you have seen with the COVID mathematical models and what happens later. I think exactly we have now some data, real data, not theoretical, and it does show. Of course, we cannot detect these mosaics, but once we detect them, we know that the presence of some abnormal cells does impact the viability of that embryo. And depending on what type of abnormality, and that's the data that we're presenting with Viotti soon, basically it tells you, it can predict if that embryo is going to implant better or worse than another embryo. So it's not perfect, but it gives us a much accurate way of selecting embryos than before. And definitely, so far, as you could see, the error rate, it's very low. Definitely not the huge error rate that has been reported by these models, and not the huge amount of embryos being tossed or falsely producing
Yeah, there's been various questions come in around the certainty of it being a misdiagnosis rather than error, and there's a lot of data on that slide that you presented. So what point, can you just reiterate at what point you need to go back to confirm that it is the right embryo, the right transfer, and a misdiagnosis, rather than, say, a lab screw up or a different pregnancy at all?
Well, I think it's important to do all these complex analysis that we do because, well, obviously for a lab, it's important to know where the error occur. If it's us, we can improve it. If it's the center, then we can tell them that they can improve it. Most of the times it could be, or it could not be a problem of either. It could be that the couple is not following instructions and conceiving in vivo. So it is important to know. And if it's technical or a human error, then we have ways of how to improve it. But if you don't know, you cannot fix it.
Thanks, Santi.
Thanks, Santi. We had another question in the chat forum, and you mentioned in the presentation the concept of in vivo conception in IVF as a root cause of misdiagnosis. I mean, it's my understanding that this most frequently comes up when there's a gender discordancy, when the NIPT is different to the prenatal testing. That's quite an interesting concept that you don't hear much talked about. How often do you see it, and how do you resolve those cases?
So I think we have confirmed at least 3 or 4 of them. But when there is, usually in these situations, what happens is that there is, we cannot follow the case to the end because the patient is not collaborative. So we have, in many instances, we reach the point in which we ask the parents for DNA of the couple because of what we want to detect, and then they say that, man, forget it. So in many instances, we are not able to trace it. When we've been able to complete the whole process, then we have found, as I said, 3 or 4 of those. So it's not very rare.
Thanks, Santi. David.
Yeah, there's been a string of questions come in really around going back to the data you presented on different biopsy techniques and the effect of poor biopsy or different types of biopsy on potential mosaic results or other abnormalities. Do you have any further comments you'd like to make on how anything that you came from this study or any other studies on biopsy technique and the accuracy of PGTA?
Well, this study didn't analyze or took into consideration biopsy. This has been, there are only these 2 papers by Whitney et al. and Grassa, and both of them indicate that depending how the biopsy is done, you could do, probably because you are chopping the cells and DNA is being released, then you could have these chaotic profiles. And if you try to identify or make a diagnosis of that chaotic profile, then it's probably when the lab gets into trouble and you could produce false results. So on the one hand, obviously, it would be good to standardize biopsy. On the other, techniques such as PGT 8.2 would be good at analyzing those samples because there will be less bias, and the algorithm will be trained appropriately on how to diagnose them. So in addition, obviously now we are going to have soon, we won't need, I guess, embryo biopsy. If we're able to do non-invasive testing of spent media. It remains to be seen. So far, I haven't seen any studies on the clinical error rate of those techniques. But I think it's time to start doing those studies. The concordance between non-invasive and invasive techniques seems to getting very close, and therefore probably it's time to start doing some prospective transfers of embryos diagnosed only by non-invasive PGT. Because all the studies have been done so far or are being done, it's like you take spent media, then you do a biopsy. So we don't know if the biopsy is affecting, again, the viability of the embryo. So unless this is done without embryo biopsy, we won't know if non-invasive is better.
Thanks, Santi. Obviously, I think non-invasive is a really interesting subject for all of us. That'll keep us in webinars for the next few years for certain. So a couple of questions that come through in terms of mosaicism and how mosaicism is detected as a threshold, and whether it's appropriate to use to subdivide mosaicism to high level, low level. I mean, what's your view on how mosaicism should be reported?
Yeah, so we did this study with Biotti, and we use different thresholds from 20, 30, 40, 50%. And then we saw where the difference, where we have more significant in differences in ongoing pregnancy rates, and actually was 50%. We used to say 40%, but now with this data that we have with Biotti on 800 transfers of mosaic embryos, it seems to be 50%. So 50% and above or 50% below gives us the more information on how to classify those embryos.
Cool. Thank you, Santi. David, over to you.
Yeah, that leads nicely into basically the next question, which was this study here was looking at, as technology evolves, we seem to have a lower misdiagnosis rate, a lower error rate, if you will. So you've been involved in many technological advances over the years. Where do you see it going, and do you think that technology advances will continue to deliver improved accuracy and sensitivity for PGTA?
Well, I think I like to see the clinical data of PGT AI2, but it seems very promising because it has lots of features that we needed. So it's fully automated. It's a combination basically of all the techniques that we want, so qualitative and quantitative. So that should be very reassuring. And then I think that now we're talking about very, very low error rates that are technical. Now we need to focus, I think, more on the biopsy or the lack of biopsy with non-invasive PGT.
Thanks, Santi. I think we just have time for one last question. I know that there was a little bit of confusion, I think, with some of the viewers, that the follow-up of results was only where there was miscarriage POC, and they were done by external labs other than Cooper Genomics. But where is appropriate for prenatal testing? I think, is it appropriate for PGTM or PGTA?
Well, now you have non-invasive prenatal diagnosis, so I would recommend it to everybody. It's just a blood sample. So
that's really good. Thank you very much, Santi. It's been an absolute pleasure having you on this Journal Club, and we really do appreciate your time. And it's a fascinating subject that I'm sure we'll be coming back to, especially mosaicism in the future.